Honorable Chairperson, respected panel and learned audience, once again a very good morning. I am Smita Kanungo from National Heart Foundation Hospital and Research Institute. Welcome you to the presentation on Closer Look Makes the Crush Better. So let's begin with our patient's short clinical history. Our patient is a 48-year hypertensive male who was working as a migrant worker in Saudi Arabia and admitted in our hospital with the non-STEMI while visiting in Bangladesh. Patient had a history of PCI in RCA in 2014 and now he had ECG revealed in for ischemia and his echo also revealed moderately impaired LV ejection fraction of 33%. So the patient underwent for coronary angiogram which revealed significant trifurcated left main stenosis, the Medina 111 classification, including the origin of LAD, circumflex and ramus. LAD has a significant stenosis at its proximal segment, also starting from its origin and giving some collaterals to the RCA. Ramus, which is also significant vessel and having 80 to 90% stenosis at its proximal and origin, and circ was a non-dominant and it was occluded. RCA, which was the dominant vessel and having multiple lesions throughout the entire length of the RCA, having some de novo as well as ISR. So having this angiographic view, we decided his syntax score was high, but considering the fact that he's a migrant worker and he has to return to his working field as soon as possible, our treatment strategy was PCI and we decided for staged PCI, and our decision was to tackle the RCA first. So while after pre-dilatation of RCA with a 2 and 3 O by 20 millimeter non-compliant balloon, RCA was treated with a 2 drug-eluting stent 3.5 by 30 and 3.0 by 48 millimeter from distal to proximal. And the post-dilatation was carried out with a 3.5 band and 4 millimeter and compliant balloon. And this is the final result of RCA, which is good, pretty good, TIMI 3-4. After tackling the right side, 4 days later, we decided to tackle the left side with the double stent strategy and decay crush. At first, while doing the left side, we have the relook of the RCA, which was fine. Now we took a 3.5 EBO catheter through femoral route. Both the vessels LAD and ramus were wear with the run-through floppy wear, which is the workhorse wear in our hospital. Pre-dilatation was carried out with a 2O by 20 millimeter non-compliant balloon. And after the pre-dilatation, we did a OCT run which showed LAD is diffusely diseased with the calcification. And here you can appreciate the calcification. So we decided to prepare the lesion bed more aggressively with a scoring balloon, and we again further dilatation was done with a 2.75 by 10 millimeter non-compliant scoring balloon. And after this scoring balloon, we had also run with a OCT which showed a rupture of the calcification. This is the we thought that we did pretty much could break the calcified lesion to a good extent while having a minimal lumen area of left main around 4 millimeters square. After the LAD, we did a pre-dilatation of ramus with a 2O by 15 millimeter non-compliant balloon, and again OCT run was taken up to assess the ramus lesion. It was also showed that the ramus had a significant lesion length and a significant lesion. The minimal lesion radius was 1.4, where the ramus origin is around 4.45 millimeters square. So after having the pre-assessment of OCT and also as well as angiographic view, ours is according to definition criteria. Considering the fact our patient has a significant side branch lesion as well as stenosis and moderate calcification and angulation. It was a complex left main PCI, and our strategy of double stent strategy was also quite rational. Now following the steps of DK crush, we took a 2.75 by 18 millimeter drug-eluting balloon from left main to ramus, and a non-compliant balloon of 3.5 by 12 millimeter was also parked in LAD. Ramus stent was deployed at 12 atmospheric pressure. After deployment of stent balloon and wire was removed from ramus, and the stent was crushed with previously parked LAD balloon. Then again, ramus was rewired with the help of microcatheter, and then a kissing inflation was done with a 3/0 by 10 and 3/0 by 10 non-compliant balloon from left main to LAD and left main to ramus at about 12 to 14 atmospheric pressure. Again, ramus were removed, and a drug-eluting stent of a 3/0 by 30 millimeter was placed from left main to LAD, and the LAD stent was deployed. This is immediately after stenting. Proximal optimization was done with a 4/0 by 8 millimeter non-compliant balloon at a quite high pressure. Then funnel keys was performed with a 3.5 by 12 and 3/0 by 10 millimeter non-compliant balloon from left main to LAD and left main to ramus respectively. Post dilatation was also carried out, and report was done with a 4.5 by 8 millimeter non-compliant balloon. And then we again check OCT run from left main to LAD, which actually revealed a significant distal edge dissection in the distal part of the stent. Here you can appreciate the dissection. So after having this OCT view, we decided to put a small stent at the distal part of LAD. So we deployed a 2.5 by 12 millimeter stent at the distal part. And this was the final OCT from left main to LAD, which actually showed a position and adequate expansion of the stent, which is very important. And the bifurcation is also open and achieving the left main area of about 16.04 millimeter square, and minimal lumen area is around 4.69 millimeter square, which is quite satisfactory. This is the final result of the left side. You can appreciate a good TIMI3 flow involving left main LAD as well as ramus. Actually, this case was performed as a live transmission in the last year, 2022. It was transmitted from our hospital to Sing Live by Professor Fazila Malik, and the patient is doing fine. Regarding OCT, it gives a high resolution reliable evaluation of coronary anatomy, lumen area, and lesion severity. It also gave the detailed assessment of plaque composition and distribution, and improved planning of the appropriate revascularization strategy. Also gave accurate detection of stent under expansion, strut malposition as well as edge dissection. And the decay cross 2 study also revealed regarding the left main bifurcation, it revealed decreased rate of MACE and stent thrombosis. So with this slide, I would like to thank you on behalf of our very hard-working cath lab team, with my sincere acknowledgement to Professor Fazila Malik, and also thank you BSI to giving me this opportunity. It's a really great privilege for me. Thank you.